Roland Halpern is the Regional Campaign and Outreach Manager at Compassionate Choices. He works at our Denver headquarters, and he represents the Mountain and Midwest districts. He has spent 12 years working with this whole end-of-life, death with dignity situation. He's lived in Denver with his wife and son since 2005. And as far as knowledge about end-of-life situations, death with dignity, peaceful dying, what have you, he is our go-to question. So please join me in giving Roland a warm Boulder welcome.
Thank you, and I again apologize for being late. I left an hour, figuring that would be plenty of time because it normally is, and it wasn't. So thank you all for turning out. It's a great turnout. You might be interested in knowing that you're among a Nobel Prize winner.
Oh.
Mr. Dudley, how are you? Thank you for showing up.
What is that?
He's a shy guy. He doesn't want to mention, but we're in good company today. So we're going to talk a little bit about the tipping point. There's a lot of questions about when are we going to see Aiden dying in Colorado. We've got it in Oregon, we've got it in Washington, we've got it in Vermont, we've got it in Montana, we arguably have it in Hawaii, and the question becomes, when do we see it here in Colorado? And it's going to be sooner than you think, I think. So just a little bit about Compassionate Choices. We are the nation's oldest and largest organization advocating for choice at end of life, and we support all choices. We support just as much the person that wants every medical intervention as the person that says, I don't want any of that. A little bit of histrionics, if you will. We started in 1980 as the Hemlock Society, a name some of you are probably familiar with. Compassion in Dying branched off in 1993, specifically to work with HIV/AIDS patients in the state of Washington. In 2003, Hemlock changed its name to End of Life Choices to emphasize some of the expanded services they were offering. And then in 2005, after conversations that took place in 2004, the two organizations merged to form Compassion and Choices, and we kept the Compassion name from Compassion in Dying, the Choices name from End of Life Choices, and that's why we have the current name as it is. In terms of funding, just to give you some ideas about it, 64% of our money, our revenues, we're operating on about a $9 million budget now, comes in from contributions. That's individuals like yourself, people that do planned giving, leave us in their wills and estates and so forth. 28% comes in from grants. Those are from foundations to do specific projects. And although we're only getting about 2% of our revenue coming in from memberships, our members are very, very important to us because those are the first people we go to when we're looking to do grassroots support, when we're looking for end-of-life consultation volunteers, when we're looking to start up new groups and areas. In terms of where the money goes, 82 cents out of every dollar goes back into our programs. Charity Navigator has given us a 4-star rating now for 8 years in a row. We're among 10%, only 10% of charities now that have been able to sustain that record. They say that if you're giving 70 cents out of the dollar back into programs, you're doing really good. So at 82 cents, we're doing really, really good. We're very proud of that rating, and you can't really see this chart up here. And actually, I should probably focus that. Hold on one second.
Hey, Roland.
Yes, sir.
That mic right in front.
Okay, so I got to do it like a ice cream cone or something. So if you look up at the overall ratings, out of a possible 70 for financial, Compassionate Choices has a 68.07, and out of a possible 70 for accountability and transparency, we have a 70. So we are right up there, so your money, when you give to us, that money is being used very, very well, and we're very proud of that, and we want to keep that. Real quick look at what our donors are like. As you can imagine, most of our donors are in the 74-year age and up. That's the new 65. That's when people now are retiring because of the economy, and when they start thinking about end-of-life planning and things like that. Beyond that, they drop off simply because they die. The average life expectancy in the United States right now is 78.8 years of age, so if you've made it past that, congratulations, you're above the pack. Down in the lower portion, we find we have the same level of support from younger people, but they support us basically in principle, but not in pocket. They're more concerned about the immediate issues, affordable health care, good public schools, environmental issues, and things like that. So financially, they're not supporting us, but we know from polling data that they're right up there with us. In terms of ethnicity, we have a problem. Most of us are what we would call white or Caucasian. And we're looking at that demographic, and we actually have a person that's trying to determine how we're going to do outreach to other ethnicities, other races, and things like that to increase it. If you look at religion, not surprisingly, about 64% are Protestant. And this is donors, keep in mind, but I think it's important to note that out of every dollar, 17.3 cents of those dollars is coming in from someone who identifies as Catholic. And I think that's very important because our opponents are always saying religion doesn't support us, the Catholics are all opposed to us, and that's not necessarily true. We are receiving money in there. And whoever among you is the Sikh, thank you very much for donating. In terms of political affiliation, we do see some wide variances. Not surprisingly, we have higher support among the Democrats, lower level of support among the Republicans. These numbers don't add up to 100%, so some people did not respond or apparently identified with a group that was not part of the survey. But the problem we have is with Republican legislation, it's almost strictly along party lines, and we've had bills that have had nothing to do with end-of-life issues in terms of a legal right to hasten your death that the Republicans have totally voted against. So we had a law, for instance, in California that simply would have given you the legal right to know what your end-of-life options were if you were terminally ill, and every single Republican voted against that bill, and the only reason we got it passed was because we had a Democratic majority. So it is a problem that we encounter. So what do? We now have 61 full-time employees located in 3 separate areas: Washington, D.C., Denver, Colorado, and Portland, Oregon. And if you add in our lobbyists, our contractors, and everything else, we now have over 100 people that are being paid by Compassion and Choices to do activities around the country. The purple color are where we actually have paid staff, and the green are where we have contractors and other people that are working on campaigns. Talk a little bit about what we do. Our end-of-life services program is one of our core programs. It's probably our raison d'etre, and that's where we work with terminally ill adults and family members, helping them to explore all the options that are available to them. We have 4 dedicated staff counselors now. 2 years ago we only had 2, so that's an improvement. We have 5 regional coordinators. 2 years ago we only had 2, so that's an improvement. We have about 110 trained volunteers operating out of 26 states. And a lot of people say, well, why is it only 26 states? Why not 50? And the answer is we get very few requests from places like Alabama or Mississippi. In fact, we've never had a request. So it doesn't pay to train somebody and to have a volunteer on the ground when there's going to be nothing for them to do. So if we did have a need in Mississippi or Alabama, we have trained volunteers in Florida, Georgia, other states that could come in and provide those services if needed. We do handle about 300 calls a month, and not all of these calls are about people looking for end-of-life information specifically. These might be people that need help with their advanced healthcare directive, their so-called living will. In planning, we get calls in from adult children that are saying mom or dad was just admitted to the hospital. The doctor wants to put in a feeding tube. I know mom wouldn't want it. I'm their proxy. Do I have to? Can I prevent this from happening? So we get a lot of calls on legal advice, if you will, telling people about what their rights are. And the teams we have are really multidisciplinary. We have a lot of retired physicians, pharmacists, psychologists, social workers, nurses, lawyers, other things. So when we get together and we talk about issues, we have a vast amount of knowledge that we can share. And so we're able to basically handle every single situation. There's nothing new to us, nothing that hasn't come up, and nothing that we don't have answers for. Clients do not have to be a member of Compassion and Choices. We'd love you to join, but you don't have to be members. We have our services available to anyone who qualifies. You don't have to be terminally ill, and that's kind of a confusing definition. Terminally ill is a definition set up by the federal government, and it's meant to mean a probable life expectancy of 6 months or less, and it's a trigger for Medicare or Medicaid reimbursement. We as an organization consider terminally ill to be incurable, irreversible, likely to result in death within a relatively short period of time. That time could be 2 weeks, 2 months, even 2 years. It's just going to be incurable and irreversible. We don't deal with illnesses like Parkinson's, muscular dystrophy, things like that where somebody could arguably live 30, 40, or 50 years longer. We can refer those people to other organizations. Obviously, if they get to a point where their disease has progressed to where it's terminal, we would be able to then help them directly. We service clients in every state, and there's never a charge for our services. So some of the other things we do, we defend physicians. This was a doctor in New Mexico, Dr. Lewis, and the medical board revoked her prescribing privileges because she believed her patients when they said twice as much works better than half as much. And we thought that any doctor who's willing to put her neck on the line and aggressively treat pain should not be left hanging out to dry. So we stepped in as an amici, a friend of the court, provided a lot of information saying there's no upper limit when somebody is on morphine and it's being titrated. We gave a lot of other information, and bottom line, she is back in business. But this is a real problem. We have a tremendous problem in this country treating pain. Doctors are reluctant to treat pain, and we think when somebody does do it properly, we should step in and defend them. And it's not like any of our patients overdosed or became addicted or anything like that. It's just the medical board looked at what was on the box and decided that because she was prescribing more than the box recommended, she was wrong. This is the Bill Bergman case. This is an interesting case we had out in California, and the doctor would not prescribe Mr. Bergman, who was dying of lung cancer, anything stronger than Demerol, which isn't even used anymore. It would be like giving you an aspirin if you had an amputation. And he was in pain every single day of his life except the last day, because when the hospital realized he was dying, as hospitals do, they discharged them because hospitals don't like people dying in them. It makes their records look bad. So he went home, hospice came in, was able to give him morphine and relieve his pain, and he died within about 24 hours. The family came to us and said, isn't there anything you can do? This is horrible. Dad was in pain. We kept asking for medication. They wouldn't give him anything stronger. And we looked at it, and in California, where the case was like in every other state, when you die, any claim you have for pain and suffering dies with you. But Catherine Tucker, our legal affairs director, said, wait a minute, California has an elder abuse statute. Let's file a suit based on elder abuse. And that's what we did, and the jury returned a $1.5 million verdict in favor of the family. That, however, was not the victory. As good as it was, within days, like within 3 or 4 days of this ruling coming down, the California Assembly passed AB 487, which now requires every physician in California, in order to get a license or renew their license, they have to take 14 hours of continuing medical education in treating pain in terminally ill patients. So now we have tens of thousands, if not hundreds of thousands of Californians that are benefiting as a result of this law. And that's out of this one particular case. We're also fighting to enforce existing laws. A number of years ago, we passed a law in California that said if you're dying, you have a right to know what your treatment options are. You might be surprised that the only 2 states where you have a legal right to know what your treatment options are California and New York. There are not any laws in any other state. Now, you might belong to a program like Kaiser that has an internal policy that says we're going to give you this information, but it's not a law. So we passed a law in California requiring doctors to give information to terminally ill patients, and we had Michelle Hargett, who was in Vitas Hospice. And for those of you who aren't familiar with Vitas, their parent company is ChemMed, the same people that own Roto-Rooter, the toilet cleaners. And they also own a for-profit hospice. And they simply would not advise her of the fact she had a right to palliative sedation, which the Supreme Court has recognized in 3 cases. And so what we're doing in this lawsuit is we're suing, saying there was a law in California that required this information to be provided. It was not, and we therefore want to hold the Vitas accountable for that. We're also trying to keep religion out of medicine, and some of you are probably familiar with the activities we had a couple of years ago when Compassion and Choices filed a lawsuit here in Boulder trying to stop the Sisters of Charity of Leavenworth for taking over St. Joseph's and a couple of other hospitals. And unfortunately, we were not successful in that endeavor. But when we do find out there is going to be a takeover, we do try and either block it or do what we call a carve-out, so that services that are discontinued can be offered elsewhere. The things we're concerned about are the ethical and religious directives for Catholic healthcare. And I'm not Catholic bashing here, so if you're Catholic, please do not feel offended. But I'd like to briefly mention two of the directives we're very concerned about. Directive 58 says that a feeding tube will not be removed even if the person has requested they don't want the feeding tube unless death is imminent. So think Terry Schiavo. In a Catholic institution, she would be kept alive until she died of natural causes, if you will. The other directive that we're uncomfortable with is Directive 60. And that says that people should be alert at the end of life, and if they're in pain, they should be taught to appreciate the meaning of Christian redemptive suffering. So it's a problem because we have laws, thank you, Ray, we have laws that state you have a right to palliative care, but we have Catholic institutions that may or may not be providing that level of palliative care. So we are trying to stop those when they come up. This one, in fact, was successful. This is Sierra Vista Hospital. It's in Sierra Vista, Arizona. The next closest hospital is 2 hours away. Crondelet, which is a Catholic healthcare agency, was trying to take over Sierra Vista, and we had volunteers on a picket line every day for 365 days, and on the 365th day, Crondelet said, well, you know what, we're really not interested in the merger, and they backed out. And so we were able to block that one, but it's probably 1 out of 20 that we're able to stop. Had that acquisition gone through, let's talk about not at the end of life, let's talk about at another portion of life. Let's say you were a female and you went into the hospital and you had to deliver by cesarean section, and you decided, you know what, I'd like a tubal ligation. I already have 4 children, I don't want any more. They would have to sew you back up and transfer you to a hospital up in Tucson that would have to reopen you and then do that procedure because that's against the Catholic directives. So, but we were successful in this particular one, so we're very pleased about that. And then we're also working towards a standard of medical care, and this is a very interesting case that we're waiting for on a ruling any day now. What we did in New Mexico, this is Dr. Morris. If you've ever seen the film How to Die in Oregon, she was the physician, the Oregon physician that was working with Cody, who was kind of the star, if you will, of that particular documentary. She took a teaching job down in New Mexico and basically has filed a lawsuit in court saying, when I was in Oregon, if I had patients that were terminally ill, I had the ability to write a prescription for them for a life-ending medication that they could then take when and if they wanted to take it. But there's a law in New Mexico that says aiding a suicide is a crime. And I am asking the court to recognize a distinction between aiding a suicide and writing a prescription for somebody who's terminally ill and dying anyway. And our argument in this case is that suicide is about choosing death over life. It's often motivated by an underlying cause like depression or something else that could be treatable if properly identified, whereas when you're terminally ill, by definition, you're actively dying. So to you, your only option is one form of death over another, and we're asking the court to recognize that distinction. What makes this case so compelling if we do prevail, and it will probably be appealed and there'll be other things going on. But right now there are 46 states in the United States, including Colorado, that has a prohibition against aiding a suicide. So if we're able to get a ruling on this, and we're in the same district as New Mexico, a ruling on this that it is separate and distinct, that opens up the possibility to passing aid and dying law. Not even passing laws, it becomes a standard of medical care, because it's just something between a doctor and his or her patient. And then, of course, you might be familiar with the Mancini case that we're trying to raise funds for defense. In Barbara Mancini's case, she was a nurse. Her father was terminally ill. He had been prescribed morphine to ease his pain. He simply asked his daughter, could you please hand me the bottle of morphine? She handed it to him. He apparently took the whole bottle of morphine. The hospice nurse came in, found him on the floor, called 911. They rushed him to the hospital, gave him an antidote. He came out of his coma, if you will. He was in so much pain, they gave him morphine and he died. And now they are holding her accountable for aiding a suicide. So we are very involved in trying to put pressure on getting the judge to rule in her favor, and we've also been raising money to try and offset her legal fees, which have been pretty substantial. I think it's over $300,000 at this point.
Where is that?
That's in Philadelphia. And then our latest campaign is unwanted medical treatment, and what we're trying to do is cut off the incentive where doctors provide services that the patient neither wanted or requested. And where we're seeing this is typically where people are admitted to the hospital, they have a DNR or they have other medical directives, and then they stop breathing or they go into cardiac arrest or something, and somebody totally ignores those directives, administers the procedure, and then whether or not the person survives, they get a bill for the services. And we think that's wrong. We think if you're not asking for it and you didn't want it, the doctor should receive compensation for it. So it's going to be a tough campaign because in an emergency situation where somebody's coming in, in an ambulance or whatever, arguably the doctors are doing the right thing by trying to revive that patient. But if they are admitted and are in the hospital and then are receiving treatment they don't want, we're trying to say you shouldn't be compensated for that. So let's talk a little bit about language, and how you frame it does make a difference. We refer to what we support as aid in dying. And aid in dying is simply the process where a competent, terminally ill individual has a legal right to obtain a prescription from their physician that they can then take when and if they choose to do so. So control is with the patient at all times. We do not support euthanasia. Euthanasia we define as the ending of a patient's life at the patient's request by a medical professional, and usually by lethal injection. And the reason we don't support it is control is with the doctor or the nurse. It's not with the individual, him or herself. We don't support suicide, and as I mentioned earlier, we feel suicide is about choosing death over life, and so that's why we don't support suicide. And for the same reason we don't support the term physician-assisted suicide, because physicians really don't assist. What a physician does is determine whether or not you have a terminal illness. They then make sure that diagnosis is confirmed with a second physician. They counsel you on all of your alternatives, and then only if all of those other alternatives prove unsatisfactory do they write you the prescription for a medication that you can decide to take when and if you want to. So I don't know how that's assisting. So we don't use the term assist, and we don't support mercy killing. And a mercy killing is typically where somebody is in the hospital in a lot of pain and the daughter or the son says, gee, it's so obvious dad's suffering, isn't there something you can do? And the nurse turns up the drip and the person slips away out of this world. And we do know from studies that over 17% of nurses in intensive care units have admitted to hastening an individual's death at least once. Wow. So it goes on quite a bit. Even in Oregon, Washington, and Vermont, the law specifically states that actions taken in accordance with the law will not constitute suicide, assisted suicide, mercy killing, or homicide. All of those continue to be against the law in Oregon, against the law in Washington, against the law in Vermont. And so this is why we don't use the term. And if that isn't enough to convince you, this is a Gallup poll that was done last year. They took a demographically similar group, split them down the middle. They asked half the group, should it be allowed by law for a doctor to help a competent terminally ill individual and their suffering if they request it? And 70% of the individuals polled said yes, they agreed with that. And then they asked the other half, should it be allowed by law to have for a doctor to be able to allow a competent terminally ill adult to commit suicide? Support dropped to 51%. So it's the same question, it's just that one word. And if we go to the legislator, to a lawmaker, and say, I've got a bill that's got a 50% chance of passing, they're not going to be real keen on that. But if we say we've got a bill that 70% of the public supports, then they're going to sit up and take notice. And this is why we have to, whenever those terms come up, we have to say to people, it's not assisted suicide. Let me tell you what it is. It's aid in dying. Let me explain the difference. You know, suicide is about death over life. Aid in dying is about allowing somebody the choice of one form of death over another. Talk a little bit about what happened in Vermont, because it's very, very unique. Vermont introduced an Oregon-style death with dignity bill with all the bells and whistles and the safeguards that the Oregon law has. It got into the Senate committee, and half of the committee said, we don't want an Oregon-style law, we just think it should be a standard of medical practice. The other half wanted the Oregon-style law, so you had basically a deadlock. It was completely tied. So the lieutenant governor came in, broke the tie by voting for the one that had no safeguards, was simply a standard of medical care. It then went over to the House, and the House wanted to insert, and they did reinsert all of the Oregon safeguards and everything into the bill, and then sent it back over to the Senate. And we'll talk in a minute about how the legislative process works. But basically, if the House sent over a bill that they knew the Senate wasn't going to agree with, the Senate wouldn't have passed it, so the Senate decided to reach a compromise. And the compromise was, we'll have an Oregon-style bill for 3 years, starting July 1 of this year, of last year, and in July 1st of 2016, the bill gets repealed, and then it becomes a standard of medical practice between the doctor and the patient. So there will be no law. It'll simply be a standard of medical care, just like it is when you go to the doctor and they might write you a prescription for high blood pressure or for diabetes or for anything else. It's going to be the same type of thing. We think it's a really forward-looking thing, and we'd love to see this in other states. And I just talked about what makes that unique. So what about Colorado? What are we going to do in Colorado? I know you've been waiting for this. So the available options that you have are a voter initiative like they used in Oregon and Washington, where you put something on the ballot and then it goes up for the election in November. We have a legislative process like Vermont used, where you submit a bill to the legislature and then it goes through the House and the Senate and hopefully signed by the governor. We have a legal interpretation like we're using in Hawaii, and we also use that in Montana, where we're looking at what we consider, I don't want to call them loopholes, but gray areas in the law where we talk about can we test this? And that's kind of what we did in New Mexico as well, looking at is assisting or aiding a suicide different than writing a prescription for somebody who's already dying? And then we have the standard of medical care. So here we don't have the legal interpretation. We don't think in Colorado we've got enough wiggle room within the statute to do that. So that leaves us open to the voter initiative, the legislative process, or the standard of medical care. Now, if we're successful in New Mexico, we might go for that standard of medical care, but we're looking farther out than that, and we're saying as good and as hopeful as we think those chances are going to be, we think probably the best way to go about this is with the legislative process. So we're going to go and talk a little bit about how a bill becomes law 101 to bore you if you forgot about political science 101. And this is just how onerous this process actually is. So starting over there, a bill gets drafted. Legislators are limited to 5 bills per session. They can only introduce 5 bills. So it has to be something that's very near and dear and important to them. And that's really a restriction in Colorado. Most other states don't have a limitation. Colorado does. So the bill gets introduced. It gets its first reading by either the House or Senate clerk, depending on which body it was introduced into. It gets referred to by the House Speaker or the Senate President. Those are the leaders of both bodies. Then it goes to a committee. And that's where the committee has a hearing, and the committee can decide to pass, amend, or kill a bill. Assuming it passes, it's called reporting out, and it then goes to a second reading for the full House, and that's a voice vote. So all in favor, aye, all opposed, nay. And if the ayes have it, then it basically at that point crosses over. And what a crossover means is it goes to the other chamber and the whole process starts over again. So if it starts in the House, it's got to go through committees, through readings, and there actually should be a third reading in there. I don't see it up there, so I must have accidentally missed that one, but there's a third reading before crossover, but then it goes through the whole process again. Now the crossover in Colorado is February 26th. So if a bill has not made it to the crossover, it's basically dead. And strategy, a lot of times committees will decide that they want to hold a bill for further discussion, and it's just a tactic to prevent it from going from the crossover. But we do have a relatively short session compared to some other states. But assuming it makes the crossover, the process repeats itself. It goes to the governor for signature. If we're still in session, the governor has 10 days to sign it. If he doesn't, it automatically becomes law, or the governor could veto it. If it's vetoed, it requires a 2/3 override. And there's also kind of another thing in Colorado which is kind of interesting called a safety clause. And most bills have a safety clause, and a safety clause means it's going to go through without the public involvement. But if it doesn't have a safety clause, then it's subject to a referendum by the citizens. And so somebody might automatically decide that they want to remove this safety clause because they want the public to decide. It's a tactic that can be used. But these kind of shenanigans go on as part of the political process. So in Vermont, basically what we had in their legislative initiative, for the House we had 97 Democrats, 45 Republicans. For the Senate, 22 Democrats. We needed 71 out of 140 votes to pass. we had 75 yays, so it only passed by a couple of votes in Vermont. In Colorado, we have 37 House seats occupied by Democrats, 18 in the Senate, and we need 43 to pass in the House, and we need 23 to pass in the Senate. So we do have our work cut out for us. Vermont was not a slam dunk. Vermont law went through after the 13th attempt. And in fact, Vermont was the first state to pass a law through the legislative process. Before that, there had been 125 unsuccessful attempts, including Colorado, to get aid and dying laws passed, and Vermont was the first. And we see that as a really good sign because we're finally able to start gaining traction in the legislatures.
Roland, I have a question about your number on the previous slide. 65 members in the House, it would be not 43 to pass.
Well, you need 2/3, right?
Not for a bill.
I'm sorry?
A regular bill passes with a majority.
I'm not sure about that. That's a good question. So the question was raised, does it require 2/3 or majority? You're probably right, it is the majority. It's not that way in every state, so thank you for that correction, and we'll make that. Basically in Vermont, it took 13 attempts to get it through. These were the two bills that were introduced in 1965 and 1966, or 96 by Peggy Lamb. Neither of them got a hearing, but we have had prior efforts to get something through. I think we are at a tipping point for a number of reasons. First, the baby boomers are getting older. And the baby boomers are what I refer to as the Burger King generation. Have it your way or have it my way. And I think this group is going to be more demanding of the type of end-of-life treatment they want and the type of things they don't want. And we're already starting to see this. And I think some of these baby boomers are going to run for office and they're going to get elected and they're going to be able to relieve some of the logjam we presently see in the legislatures. Medicine, doctors are finally recognizing that patients die. This was kind of a novel thing for them to recognize because most medical schools are still teaching that death is a failure. And one of the problems we have with hospice is doctors are not referring patients into hospice until they finally figured out, geez, there's nothing else I can do. And usually by that time, it's too late for hospice to reap its full benefit. So it's an education process, but we are making progress in that regard. Doctors do realize that patients are sometimes going to die, and so that's changing it. And we actually have, the most recent poll shows us about 59% of physicians support the option for a patient to obtain a life-ending medication if they're incurable and suffering. So we are there now. 15 years ago, it was like 30%, so we've come a long way on that one. Also, last year, there were 7 legislative bills introduced for aid and dying. That's been the most that's been introduced in any legislative session. So we're seeing traction. I don't know what this year is going to show in terms of bills being introduced, but it's probably going to be at least 7, if not more. We still have active bills, I should say, that carried over in Massachusetts and in New Jersey. And so we're working on those. New Jersey's a problem because Christie has indicated he would veto any bill that comes to him, but we're still working on that. Public support going back to 1977 has been at or above 60%. And the irony here is if any other issue had public support over 60% for so long a period of time, it would have automatically been a law. Unfortunately, it's not, and the problem is organized religion. That's our biggest impediment. And again, I'm not trying to bash organized religion. So our work's cut out for us. The main sources of opposition are religion, Republicans, and I'm not talking about Republicans that might be in this room, I'm talking about legislators and governors, disability groups, and the American Medical Association. This is just a map of religiosity based on church attendance. And it's not surprising the places where we have laws or have some option available to people tend to be towards the least religious. There in Colorado, we're about, not really in the middle, 35% to 39% of residents in Colorado say that they attend church on a regular basis. So it's not going to be as easy as Oregon or Washington, but it's not going to be as hard as Alabama or Mississippi or Arkansas. This is just a USA Today poll asking people in Colorado what their religion was. 23% identify with Catholic. I think it's encouraging to see that 21% don't identify with any religion in particular. So that leaves us some good room to go after. And I won't go through all of that, just to show you that. But religion, the religious opposition is sizable. This was the Massachusetts ballot initiative, and this is just what was contributed by the Catholic Church or Catholic entities within the last 2 weeks of the campaign that went to buy television advertising. $2.1 million. Okay, and we couldn't, at 2 weeks to go, we could not match that kind of money. But the Boston Catholic Television Center alone donated $1 million. So this is the kind of thing that we're up against when we go into one of these legislative or voter initiative campaigns. In total, I think probably $6 million was spent in defeating that particular effort.
What was the percentage?
The percentage of?
The election result. I mean, how close was it?
The outcome was 51 to 49. Which is exactly what we saw when this was tried in Maine in the year 2000. And what happens in the last 2 weeks is they pre-buy a lot of television advertising, and they put these really scary negative ads on that have nothing to do with the issue itself. In the case of the Maine campaign, they had this beautiful, like kind of sepia-toned thing of a train rolling into the station, and all the seniors were being herded into boxcars, and then the train disappears into the mist. And it's enough to scare people that are on the fence and undecided, and that's why we lost. And they use similar tactics in Massachusetts. You know, the church itself, here's Cardinal O'Malley. He urges the parishioners, to go against it. And so you're charged from the pulpit, I want each one of you to contact your legislator tomorrow, or I want each one of you not to vote for this. It's a problem. In this particular case in Connecticut, the Republicans threatened to filibuster. The bill looked like it was actually going to go through, and on the last couple of days of session, they said, unless you strip that bill from the agenda, we're going to do a filibuster, and then none of the other bills are going to get passed. And so they had to drop the bill so they could pass some other important bills. But this, again, is an example of some of the things we run up against. House Human Services passes out Death with Dignity Committee. Split along party lines, Republican Party all voted against the bill. So again, I'm just trying to show you some of the problems we have. This was the vote in Vermont. Not a single Republican legislator voted for the Death with Dignity bill. And then we have the group Not Dead Yet. And they did take their name from the Monty Python film, for those of you who might have seen that film where the person says, I'm not dead yet, and then they conk him on the head. But their concern is that they think they're going to be targeted, and because they have disabilities, that if we pass aid in dying laws, it will only be a matter of time before we decide, let's get rid of the disabled, let's get rid of the uninsured, let's get rid of the elderly, let's get rid of the frail, all of that kind of thing. So they're demanding equal protection against so-called mercy killing. But I think it's interesting because the words they use when we talked about language earlier, look at the words they're using. Assisted suicide, euthanasia, mercy killing. And that's why we don't use those terms, because it only feeds into them. So looking ahead into 2015, it takes more than a village. And what we need is we need everybody here to get involved if we're going to move ahead and get a bill introduced and get a bill passed. And I think it's doable. It's going to take a lot of work, but I think it's doable. First, you can become a part of a local planning group, and we're looking for people not only in Boulder and not only in Denver, we're looking for people in every major city, and by a major city I'd probably say population 20,000 or more, for somebody to become a captain, just a point person that's somebody we can go to if we're having an event and we want them to have a table or have a booth and pass out information. If you're interested in public speaking, we'd be more than happy to train you how to do that, pack you up with a PowerPoint projector, and send you on your way. And we have a lot of really good volunteers, like Lynn Weitzel right now is one of our volunteers who's probably doing a presentation every 2 weeks, traveling around Colorado for us. You can help us identify speaking opportunities. If you don't want to speak yourself, do you belong to a Rotary Club, a Bridge Club, any other kind of club that's looking for public speakers? Let Ray know, and he can arrange for somebody to come out and give a presentation. Meet with your legislators. go down there and talk with them. And even if they don't support it, they should still know that they have constituents that do want an aid in dying law, and they should understand that, and they should understand that you vote, and maybe if they're not going to support that, you just might not vote for them. They need to know that. When you see opportunities come up, write a letter to the editor. If it's a situation where somebody had to resort to violent means to end their life because they were suffering, we should write a letter and say, wouldn't it be great if there were a better alternative? Wouldn't it be great if we had something like Oregon has, where somebody can go to a doctor and get a medication? You can volunteer to participate in a phone tree, and that simply means you're on a list, and prior to a meeting like this or any other meeting, you'd get a list of 5 or 10 people, and you'd call those people and say, hey, I'm going to be at the meeting on Saturday. Will I see you there? Can I expect to see you there? It helps to boost the attendance. Or, have you heard about this bill? We need you to contact your legislator and talk to him or her about it. You can help gather petitions, and we have signature petitions, which just requires your name, address, and your email address. And we're building a database so that when things come up, we can reach out to you and get this information to you. If you want to host a house party, we can talk to you about that. We can have somebody from Compassion and Choices come out and speak in a more intimate group about end-of-life issues and why we think this is important. And I already talked about becoming the captain in your particular area. So, what's wrong with this picture? The adult population in Colorado, according to the 2010 census, is about 3.8 million people. Of that 3.8, we have a potential of 2.3 million supporters, and I'm basing that on that figure we talked about earlier, where we know about 60% of the public supports the issue for aid in dying. There's about 2.8 million registered voters in the state, and again, this is relying on prior data. 2.5 million people voted in 2012. This is the sad number. This is the number of members and supporters we have in Colorado right now that are in our database. So we've got a potential of 2.3 million people that are going to support our issue in this state. Today, we can only reach 1,212 of them if we had to, directly. And that's why it's so important to gather the petitions, to talk to friends, to get more names on there. We've really got to kick that up. I can't go down to the ledge and say to somebody, we want you to introduce this bill, and guess what? We got 1,212 people that are going to support this issue. Not when the Catholic Church has probably 600,000, 700,000 people that they can turn out. It's probably higher than that. So we really do need your help. This is what the petition looks like. I do have petitions here that people can take with them if they want. All you have to do is talk to your friends, neighbors, or whatever. It simply is saying that we feel strongly that people in Colorado should have the right to decide on end-of-life issues. And as you can see, it's just name, address, and your email address, and it's nothing more than that, a phone number too. So it just allows us to collect the information and to contact you when something's coming up. So in closing, you're in control. I point out to audiences, I'm a vegetarian, I've been a vegetarian for a while, but 10 years ago when I'd walk into a supermarket, there weren't a lot of options. Yeah, there was a produce section. But today, I walked into King Soopers, and they've got a whole aisle of organic food and vegetarian food. Why? Because the consumers want it. We've got to look at this as a consumer issue. We're the ones with the money. It's our insurance dollars that are paying for medical care and assisted living and all of these other things. And so we should be telling the doctors in the medical care facilities, this is what I want. And if you're not going to deliver it, I'm going to spend my money somewhere else. You've got control. So think about that. We're in the driver's seat. So in the words of Martin Luther King, in the end, we'll remember not the words of the enemy, but the silence of our friends. So please don't be silent. Get involved. And I now open it up to Q&A. Yes, Bart?
Roland, can you explain, please, the distinction between the medical standard of care? You referenced that was a more forward-looking scheme, and how does it provide better safeguards for us than a law?
Okay, the question had to do with the medical standard of care and how it would provide better safeguards than a law and how it would work. Basically, with a medical standard of care, if you think about it, there's very few laws that regulate how doctors practice. They have to have a license. In some states, they have to have continuing medical education. But beyond that, there's no law that tells a doctor it's okay now to prescribe this medication, or it's okay to perform this surgery, or it's okay to start this person on chemotherapy. They leave that up to the physician's best medical judgment. We think that aid in dying should be the same way, so that it's part of the toolkit that when you go into the doctor and you talk about options, it's one option that they can bring out. The beauty of it, if you will, is it's not regulated as a law. It's not under religious control unless the doctor happens to be a Catholic doctor or working for a Catholic facility. So it allows for, I think, much greater exploration, if you will, of the options that are available. What happens with the standard of medical care is they leave it up to the medical boards and the medical community to decide what rules they're going to follow. So it's not a law, but there are guidelines that are set up by the medical community. So, and we're not sure, we're looking now at what's happening in Vermont, where this is, where the medical community right now is going through that process, because as I mentioned, the law disappears in 2016, and we're going to see what comes out of that and what type of guidelines they come up with. Fortunately, the state of Oregon has developed all the way back, I think in 1998, they came up with guidelines that medical practitioners can follow to make sure that the request is a valid one, that the person's not being coerced, that there's all of these other safeguards in place. So, yes?
Yes, I apologize in advance if this sounds like a trivial question, but when I turn my computer on in the morning, I do not feel in control. I am not worried about the silence from my friends. I would like to sign up, and did sign up in the back for this, I'm on the email list. I just want to know, how often am I going to hear from you?
The question is, if you volunteer, put your name on the list, how often are you going to hear from us? It's really going to depend on what's going on. Right now in April 16th is National Healthcare Decisions Day, and we're going to be looking for volunteers simply to sit at tables, for example. We might even have one here at this senior center, at the East Senior Center, and simply pass out advanced healthcare directives and information on the organization so that more people are familiar with it. If we get a bill introduced, or I should say when we get a bill introduced, and that's going to be a couple years down the road, we'll be calling everybody and just saying, can you contact your legislator and tell them you support this bill? So it's not going to be like you're being contacted every single week. It might be several months before you get another contact. Obviously, when there's a meeting, you'll be contacted about that. If there's something important, you would be contacted about that. But it's not like you're going to be deluged with junk mail or robocalls or anything like that. So I hope that answers the question. Yes?
What about insurance? If someone dies with aided death, does it affect insurance policies? Does it affect medical insurance?
The question had to do with insurance and whether an aided death would invalidate an insurance policy. In the laws, in the states that have laws, Oregon, Washington, Vermont, there's a specific section of the statute that says it will not invalidate an otherwise payable policy. Now, the other thing is, in every state except Colorado, which is only 1 year, but in every other state, which is 2 years, for a typical life insurance policy, we're not talking about a military policy, we're talking about Hartford or one of those other companies, there's a 2-year incontestability period. And the insurance company has only 2 years from the date that they issue that policy to investigate that particular policyholder and decide whether they want to cancel that policy, make it null and void or whatever. After 2 years, it does not matter. As long as the premium has been paid, they cannot deny a payout to an individual. Now in Oregon, Washington, and Vermont, the death certificate doesn't say they use the aid in dying law, or it doesn't say other than natural causes. They list the underlying illness. Cancer, cardiopulmonary obstructive disorder, emphysema, whatever it happens to be. So the insurance company, if they get the death certificate, is never going to know that the person used the law. That's another nice thing about doctor-patient, It's confidential, it's protected. But it's a great question, we get that quite a lot, but it will not, as long as the policy's been in effect for 2 years, it's not going to invalidate it, unless it's a military policy, and even then there's questions. And any insurance company that writes a policy for a terminally ill individual, I think deserves to make a payment for not doing due diligence and checking that out. Yes?
Well, I was back to the standard of care for medical practitioners. Does that allow individual doctors to decide whether they want to, make aid and dying available? Do they have choice then?
Yes, the question had to do with, does a doctor have to participate? And absolutely not. And even in Oregon, Washington, and Vermont, the statute says if a doctor is religiously or morally opposed, they simply do not have to participate in it. I mean, certainly you wouldn't go to your pediatrician if you've got kids and ask for this, or to your dermatologist. It would have to be somebody that's familiar with infectious diseases or age-related diseases, that type of thing. But and even a pharmacy, if a pharmacy says, we don't want to fill this prescription, we have this problem with contraception, we don't want to fill this prescription because we know what it's being used for, there's no law that requires the pharmacy to do it. So it's really up to the doctor and the patient. And so we encourage people, when you meet with your doctor, to have that conversation. I mean, my insurance program, that I have through Compassionate Choices, it seems like every year I have a new doctor. I never see the same doctor. That's just how the plans work. But when they ask me, well, where do you work? I say, I work at Compassionate Choices, and here's what we believe in. And if it came to that point, would you be willing to help me out? And usually most of them are kind of agreeable. Well, I'll do what I can to keep you out of pain. And for me, that's good enough at this point. Because we don't have a law. They probably don't want to go further than that. But it's a question that should be asked, while you're still healthy, or at least before you get to the point where you're really going to need it. And if your doctor says absolutely not, then you might want to see about finding another doctor. Over here, and then I'll get back over to that
You should
side.
not only ask your doctor, but you should ask about the partnership that he functions within.
So the comment had to do with the partnership, and we talked about the ethical and religious directives earlier for Catholic healthcare. If a doctor is practicing in a Catholic hospital or Catholic clinic, they actually have to sign a contract that says even in their private practice, they will adhere to the ethical and religious directives. So even if I'm a physician and I work in a Catholic hospital, but I have a totally separate private practice, in theory, under the contract, I still wouldn't be able to write a prescription for contraception, or I still wouldn't be able to remove a feeding tube or anything like that. So that's a problem. But yes, I mean, you should check into that too. Over here, and then I'll get back to you, sir. Yes?
Roland, I'm Lance Wright.
Hi, yeah, Lance.
Roland and I have been having a conversation intermittently for a couple of years about what needs to be done in Colorado. I have Parkinson's, and I think that we need to look at moving ahead sooner rather than later. I'm encouraged to hear that there is considerable movement compared to what I encountered a couple of years ago when I first started talking with you folks. But what I'm curious about now is we're talking about lobbying, and we're talking about a political campaign that you said might generate legislation 2 years from now. Supposedly it took 10 years or so for Vermont to be moving forward. I think we need to get started now, and I'm wondering what we need to do to follow up on Dottie Lamb's editorial that she wrote 2 or 3 months ago, saying assisted, what's the proper term?
Aid and dying.
Aid and dying, I get myself confused in this. Aid and dying is the next civil right. And I'm not sure what sort of response she's had, but I know that there are folks who are familiar with the political arena that are willing to do stuff and move forward. And I think we need, are you going to do that, or are you going to have someone else do it? I know there are other organizations, in particular the Death with Dignity organization in Oregon, that seems to be more aggressive than Compassionate Choices and where they go.
We're all going to do that, Lance. And I mean, that's one of the reasons we're here. We've got to pump those numbers up. At 1,212, we just don't have enough clout. And so the first thing we need to do is we need to build up that supporter base. When we get to that point, we are going to hire lobbyists. We're going to have a state director that's just singularly focused on this campaign. I mean, that will all happen. That's what we've done in Vermont. And in fact, we have a Vermont state director right now who was part of that campaign, who is now dedicated solely to making sure that Vermont law works. So that all follows, but what you need first is the numbers. We need the numbers, we need the letters to the editor, we need people talking to their neighbors about it, and all of that before we really have a good chance of moving forward with this.
What are you aiming at when you say build up the numbers? It seems to me that you would have to have a goal, or would have to state this organization, this group is pushing toward legislation in 15 or 16 or 14 or whatever it is, and we're operating now and we're established and we're moving forward. Is that in the plans, or is that something that I'm going to have to do, or Dottie's going to have to do, or something?
No, it's in the plans, and as to the number, that's a good question. I don't know whether it's 200,000, I don't know whether it's 500,000. What we need to do, though, is we need a core base in every legislative district. Because right now, we've only got Boulder County and we've got Denver, but we don't have people, at least that have identified themselves as captains in those other areas. So we need, when a bill gets dropped, we need people from every district to be calling their legislators and saying, I support this effort. Because for me, from Denver, to call and talk to somebody that's up in Greeley or down in Pueblo or whatever, they're not even going to listen to me. They just, what's your zip code? Click. I mean, that's how it works. So we need to increase that base and have someone in every single legislative district. So I don't know what the number is right now. 200,000, 500,000, I don't know, but it's got to be enough to make a difference and to make a noise.
I guess I'm not making my question clear, is that to get to that number, we need some sort of a focused program, I believe. That we're saying this is, the goal is to get the legislation. We have to raise support. So what are you pushing? Well, you're pushing getting to legislation.
We're pushing getting names on those petitions. We're pushing on everybody taking a petition and getting their neighbors to sign it. And then once that petition's filled up, if you want more, we'll send you more. And that's how we build up the numbers. That's what we've got to do. And every name on that petition is somebody that will receive a note saying, would you be interested in circulating a petition yourself? So we're hoping that it'll create ripples in the pond. But that's what we need. Without those numbers, we're not going to be able to do anything. And we need those numbers first.
And that's out of your headquarters?
That's out of Denver is how we're going to be doing this, yes.
I'll set it out for now, but I'm here and I'm interested in chatting with anybody that wants to talk about this further too.
Okay, thank you, Lance. Yes?
So this is being recorded this morning. Are you going to have it on Denver television so people in La Junta and so forth can see it?
You'll have to ask Ray, because I think he posted on the Boulder website, and so...
He posted on the Boulder website. It'll be on there in a few days.
So you'd have to tell people about that.
But I mean, not on Channel 4 or Channel 8 or something. I mean, that would...
No, we don't have a way of doing that right now.
And we're not at that point right now, I don't think. We're still building that grassroots support, but it'll get there. I mean, the media's not going to be interested in it until we get something really substantive going. And we're just not at that point yet.
I disagree. I think the media would be interested.
Well, if you have any ins to the media, we'd be happy to. You had a question back there, sir? Yes.
I'm a retired trial lawyer, and advocacy is my field, so to speak. I think you made an excellent presentation. I was very impressed with what you had to say. There are a couple of suggestions I would have. One is, if you could put together a pamphlet about how to be a compassion and choices advocate, would be a useful device at a group like this. It's already sympathetic to your message that would enable each one of us here to know how to approach other people in a way that would be effective and as an advocacy. In fact, you might want to put together an advocacy team of people who have tried to look at the most effective ways of influencing other people to join our group. That's one suggestion. And the other one was the only thing in your presentation that I thought was missing that perhaps ought to be included would be to say a few words about that the legislation in those states that have passed bills have had a provision about competence, that we're not really that we want to ensure that people who are not competent make decisions to end their life, and that you know, that what is required to meet the barrier for a competent decision making.
So thank you. One of the observations was we need to put together a pamphlet or something that tells people how to be an advocate, and that's a great suggestion. I mean, we have pieces, parts of it, but it's not together, so we'll do that. The other thing, in Oregon, Washington, and Vermont, the law does have specifics for competency. Basically, it's not only your doctor that has to diagnose the terminal illness, that has to be diagnosed by a second physician, and if either physician feels the individual is being coerced, might not fully understand what they're asking about, things like that, they have to be referred for a psychological evaluation.
No,
So,
I understand that. I'm just
Okay.
saying that should be made part of your presentation.
Okay. So, yes, you've been waiting patiently over there.
Thanks for taking my question. For now, at this time, if there is a internally ill person, then he would like or she would like to end his or her life, can compassion and choice help with the fact that she or he is the resident of Colorado? Can he or she travel to one of those states to have that benefit, or right now there is nothing really going on for him until that becomes to the law? With an idea of there is an organization in Switzerland called Dignitos, then you can travel to that area and take care of it.
So the question had to do primarily with residency, and we get that question a lot. The doctor in Oregon, Washington, or Vermont has to be satisfied that the individual is a legal resident of the state. And the way that they suggest, there's no specific requirement, but what the statutes state is residency can be proved by a driver's license, a valid state ID, proof that you filed income tax returns for the most recent tax year, or proof that you're renting or leasing property. So in theory, you could get on a plane, move to Oregon, and establish residency probably in 30 to 60 days. There's not like an actual time requirement, but it's not like you can just get on a plane and go there. Part of the, I don't want to call it a problem, but the way they've set it up on purpose to prevent what some people call suicide tourism is you not only have to find that doctor, and keep in mind it's not easy finding a doctor these days at all, no matter if you're a resident or not. You have to find that doctor. That doctor is going to have to refer out for a second consultation. Part of the process is you have to have two witnesses sign a statement saying that in their opinion you're making a rational and well-informed decision. And if you happen to be in Oregon or Washington and all your people are back here in Colorado, they're not going to be able to sign for you, so that's kind of an impediment as well. And they've done that by design. They just don't want, they only want it legal for the individuals in their state. But you could move there, you could establish residency, but it's not something where you, like Dignitas that you were referring to, which you can make an appointment and just go over there and then they give you medication. Now in Colorado, I mean, we do have options. We don't have the option to legally obtain a life-ending medication, but we have voluntary stopping of eating and drinking. A couple of years ago, some of you might have been here when we brought Neil Rudolph here, and he talked about his parents who decided to stop eating and drinking, and it was a relatively peaceful ending, supported by hospice and a lot of care. And you also have the right to palliative sedation. Everybody has a legal right to that, and that's basically where you're put into a drug-induced coma, and they just don't bring you out of sedation. They just withhold any further life support and allow nature to take its course, and that can take several days, or in some cases several weeks, depending on that. So it's not as good as having the medication, but we do have options in every state. It's just we don't have the option that most people want, which is the very quick and easy option that's available. Yes, ma'am.
Those options you just mentioned are only for the terminally ill, right?
No. The question was, are those options only available for the terminally ill? No. In the Rudolph's case, they were both well into their 80s and neither was terminally ill, but they had a confluence of different illnesses that were just making their life miserable. Their organs were starting to fail, there were a lot of problems, and nobody can force you to eat. You have a right to stop eating and drinking right here and now, and that's what fasts are about when they do those things for demonstrations and things. Nobody can force you to do that. But the thing is, you do need support on that. And one of the things that happens when you do stop eating and drinking, you will become terminally ill within a very short period of time, because you do start to experience organ failure. If you have no fluids coming in, your kidneys are going to start to fail. You'll have organ failure, you will become terminally ill. And that could be within 3 to 5 days. So our experience has been, if somebody wants this option, they usually contact hospice before the fact. And most of the time, hospice is agreeable to working with the individual before they even stop eating and drinking, because they realize it's going to be a terminal situation. But you have to talk to the hospice beforehand and make sure that they're agreeable to doing that. We have for-profit, not-for-profit. There's religious hospices. There's hospices that are part of managed care programs like Blue Cross Blue Shield, that sort of thing. So it's a conversation that has to take place beforehand. Yes, sir.
I just want to say thank you for your excellent meeting.
Okay, well, thank you for coming.
Thank you very much.
Okay. Yes, sir.
Your slide that showed not dead yet reminded me that maybe we should turn to the enemy or our opposition for support. Hemlock had a annual meeting in Ann Arbor a few years ago, and back when it was, and we were instructed to go out the back door of the hotel where we were meeting because we were being boycotted by Not Dead Yet. So I went out the front door and talked to them. And I told them what I had done with my mother and how I had hastened her death by massive doses of morphine. And they listened to that, and they told me what they were concerned about, and they said they would support me 100% in what I had done and what I perceived we were trying to do in Hemlock. But they didn't understand it. They were scared of what they didn't understand. Listening to the Pope, I'm not so sure what the Pope would listen to you. Turn to your enemy will be your support.
Well, and we do try and reach out to other organizations, and when we have dialogue like Not Dead Yet saying they're opposed to it for a certain reason, we at least try and set the record straight. And we point out with disability groups, and it's not all disability groups that are opposed. We actually have a couple of disability groups, Autonomy, for instance, which is one of our supporters, and that's a disability group. There's a distinct difference between being disabled and being terminally ill. And that's what we point out to them. And, you know, that community is marginalized, just like some of the minority communities are. And I understand the concerns, and we understand the apprehensions that some of those people have. And we're not trying to change their opinion. We're just trying to say we'd like to get the record straight. And I see the cane coming to haul me off stage here. So we'll go ahead and end. But I'm going to be around for a couple of minutes. You know, if people have questions afterwards and they want to come up, I'll stay as long as you need me to stay.